All right. It's the top of the hour, so I think we'll jump in. I'm David Glazer.
And I'm Katie Burkhart.
We're coming to you live from Geneva. Unfortunately, it's the conference room version, not the actual one. I think Katie and I bit off more than we could chew today. We've got the topic Understanding Medicare's Supervision, Signature, and Order Policies in Clinic and Hospital Setting. There's a lot of stuff to cover. So we will do almost no housekeeping, as usual. I will just do a couple of quick things. First, remember over the lunch hour, sound sometimes gets kind of hinky. If it does, you can always dial in. Robert's typing numbers in the bottom right corner, and you can dial in that way. Our next webinar, I'm hoping, will be as popular as this one was. On May 9th, once again, Katie and I are going to be talking about short hospital stays. And what I think will make this one appealing is we're going to be talking about how you challenge denials. So physicians will probably be a little less interested in this one, but for hospitals, this is a big deal. How you challenge short hospital stays. All right, so let's dive in. First, understanding the big picture, we're talking about Medicare here, and so there are all kinds of signature requirements. You could have state law, private payers, Medicaid, all of the various accrediting bodies, including the Joint Commission. You can have standards of care, and you can have whatever your local whistleblower thinks at the moment. We may allude to a few of those things, but we're really focusing on Medicare. Second point, and this is a very important point. Whenever you're talking about signatures, there's kind of two things to consider. There's the safest approach, and there's the what could we aggressively argue in an appeal. I think both Katie and I like to be kind of creative, and so we will often come to what we can think is most defensible in an appeal. But that isn't to say that the practical advice in most of these cases will be sign the darn thing. Next point, we will be talking at we'll be talking more articulately than I am right now, hopefully, about conditions of participation, which are different from conditions of payment. We're really going to focus more on the conditions of payment than on the conditions of participation. There's a reason for that, which is we hope they're different. Unfortunately, right now, it's only a hope, and so let me explain that. First, there's language in the program integrity manuals, and if you really jump down to the bold on the second part of the slide, if during a review it's determined that a provider doesn't comply with conditions of participation, the carrier is not supposed to deny payment solely for this reason. Instead, they turn it over for the person to be defrocked from Medicare. That's been our historical position. There's an interesting question evolving right now as to how that's going to play out in the future. Our enrollment guru, who happens to be sitting next to me, may offer some quick advice. What's going on with Medicare enrollment right now?
Well, there's a lot going on, and most of it comes from health reform. But the first big thing that you should know is that CMS has announced that it is going to revalidate all of the physicians, non-physician practitioners, and suppliers at some point. Now, they've started with, I think it's 105,000 physicians and non-physician practitioners that have supposedly received requests for them to submit their revalidation information. So if you want to know if you're on this list, CMS has actually made it available, and I'd be happy to check that for you. But it's really important to respond to revalidation requests because this is where CMS is going to ask you to update your enrollment information. And enrollment information is really important to get correct.
Now, why are we raising this right now? One of the changes in the enrollment information is a change in the certification you sign when you submit it. I have in front of me the 855A language, which is what applies to facilities. There's also a B, and I should grab the B language because I don't know that it's identical. But here's a scary sentence. I understand that payment of a claim by Medicare is conditioned upon the claim and the underlying transaction complying with such laws, regulations, and program instructions, and on the provider's compliance with all applicable conditions of participation. So there's the condition of participation element in there, but there's also this requirement that you comply with program instructions. So, Katie, do you think are the manuals program instructions?
Well, it's interesting because most of the manuals are program instructions or are instructions to CMS's contractors. So my counter to certifying that you're complying with the program instructions would be that you don't have to comply with an instruction that isn't directed to you. However, some manuals are less clear. They appear to be directed towards a more general audience, including physicians, suppliers, etc. So what's interesting about this new certification statement is that it sort of brings in all of these perhaps manuals, transmittals, maybe even guidance from the carriers within the realm of things that now CMS thinks that you're certifying to complying with, which is a scary, scary thing.
And I would like to argue, and we have not yet thoroughly researched whether you can make a straight-faced argument that manuals are not program instructions. I think that there may be such an argument to be made, but I wouldn't bet the house on it right now. I guess one of the lessons is I can feel the vice tightening on physicians and hospitals right now. So I just mentioned that. Okay, next part of the big picture. There's an increased focus on causing a claim to be presented, which is one of the elements in a false claims action, is that you can get in trouble either for submitting a false claim or for causing a false claim to be presented. So, Katie, doctors routinely get certification forms to fill out for, home health or something like that. Do they need to care about these puppies?
Well, sometimes all these forms seem just like a lot of paperwork that doesn't matter. But as this becomes a bigger deal where the government's focusing on causing a claim to be presented, if you are indeed certifying something or signing something that says this is the certification statement, then it can be argued that you're causing a claim to be presented that you certify is correct. So it's bottom line, paperwork is a big deal. Make sure you know what you're signing.
So, all right. And the last point, and this is going to come up, Katie will be dealing with this more probably than I, but the regulation and guidance on signatures is often inconsistent. Sometimes you can harmonize it. Sometimes it's facially inconsistent, but if you pay careful attention to the wording, you can find a way to harmonize seemingly disparate statements. But in a few of the instances, it's downright contradictory. And so you can find a section that says you don't need to sign a form, and then you can find a section that says you do. And actually, I guess I'll be talking about an example when it comes to office notes for physician signatures. All right, I'm not going to spend any time talking about the agenda. We did struggle a bit in how to organize today, so we're going to start off kind of talking about supervision. We'll move on then to Incident 2, then signature requirements and orders, and kind of end there. All right. Big picture, I'm not going to spend long going over the law, especially because we don't want to bore you to death. But it is helpful to look at the Friendly Medicare statute for a moment, because it defines things in ways that affect the signature requirements. And one of the things to understand is that the Social Security Act lists different benefit sets. So the first benefit is physician services, which is different than the benefit that is services that are an incident to a physician's professional services, and we'll talk about that. That everyone uses the phrase incident to, and what that comes from is that the service is an incidental part of a physician's service. It's really just, I think, designed to confuse. And then there's a third benefit, which is diagnostic X-ray tests. These are 3 distinct benefits under the law, and that ultimately is going to matter because well, we'll explain why and when we get there. But it's just important to note that, and we stuck the laws in here right now. Another thing that's just kind of worth a quick glance, this is the portion of the Act that refers to nurse practitioner services, and there's almost identical language for physician assistants and for clinical nurse specialists. And it says, basically, if a service would be a physician's service, and it's done by an NP or a PA or clinical nurse specialists, then the NP or PA can bill it themselves. A thing to note here, I have often shorthanded this as anything a doctor can do, an NP or PA can do if it's in the scope of practice. That's not right. My shorthand when I do that is wrong because it only talks about services, and the importance of that will be clear in a little bit. Now, let's talk about the supervision of diagnostic tests. Medicare has created 3 levels of supervision: personal, direct, and general. And the way you find out now we're only talking about diagnostic tests. And
And we're also only talking right now about in the office setting.
Excellent point.
In the non-hospital setting.
And that's it. So this is why this is going to be somewhat confusing. Katie's going to talk about hospitals in a minute. So this is offices, and it's nothing that's therapeutic. And she'll go more into that distinction. But if it's not a diagnostic test, what we're about to say, if it's not a diagnostic test in the clinic, you can blow off what I'm going to say. So every year, Medicare puts out the fee schedule. And the fee schedule lists all of the things that are considered diagnostic tests. And actually, that's one of the things you can check, because some of the things you might think of as diagnostic tests really are not. And those are listed in the code as no level of supervision is necessary. Otherwise, it needs personal, direct, and general. So what does that mean? Personal means the doctor has to be in attendance in the room during the performance of the procedure. A classic example of that is the stress test. So the doctor has to be literally in the room. The next level of supervision is direct supervision. This gets mushier. It says that the physician must be present in the, quote, office suite and immediately available to furnish assistance throughout the performance of the procedure. It then helpfully says that it does not mean the physician must be present in the room. So we know they don't have to be in the room. It tells us what it isn't. It doesn't really tell us what it is. So what does in the office suite mean? This has been a question that's been around for as long as I've been a health lawyer, which sadly is coming up on 20 years. We don't know exactly what it means. When I was a young pup, we used to say it was the 30-second test. Can you get there in 30 seconds? It wasn't the test after the 31st test. That's pretty decent. It's not etched in stone. We're not, there's no legal authority to back that up. Do you have to be in the same building? There have definitely been carriers that have said the answer to that is yes. And it feels like if you're in a different building, the situation gets a lot weaker. Now that, of course, can be logically crazy because often, especially in cold climates like Minnesota, you may have two buildings connected by a skyway, and you could be in two different buildings and literally closer than you are if you're on the first floor and the third floor. Is that okay? We don't know. There have been very few published cases on this. There's very little written guidance. Here's one of the few things that's ever been written by this, and you'll notice it's not a final rule. It's a proposed rule that came out in 1998. And I'm just going to read it to you because it'll tell you as much as you can. So we're not proposing that there must be any particular configuration of rooms to qualify as one suite. However, the physician must be in the office suite. Thus, a group of contiguous rooms should in most cases satisfy this requirement. Well, doesn't it in all cases? Which is what I would have thought. We've been asked whether it would be possible for a physician to directly supervise a service furnished on a different floor. We think the answer would depend upon individual circumstances. The question of physician proximity is a decision that only the local carrier could make based on the layout of each group of offices. A carrier might decide that in certain circumstances it's appropriate for one room of an office suite to be located on a different floor, such as where a physician practices on 2 floors of a townhouse. Well, that's helpful and clear, isn't it? Practically, I still stick with my 30-second test. I think that if you can get there, to respond to a code, I'm going to feel very comfortable defending you, but you take a little bit of risk if you get further than that. Okay, last level of supervision, we're talking about supervision of diagnostic tests. All right, let's try that again. Of general supervision. Now, this is another one where I used to cavalierly say I used to define personal as in the room, in the suite, and then as general as on the planet. But that's too cavalier because if you read what the actual requirement is, you have to be responsible for the training of non-physician personnel and maintaining the necessary equipment. Now, this is an interesting one because the truth of the matter is I think very few physicians meet this. I feel like it's asking me to be able to supervise could I fix the copy machine? Can a doctor fix the x-ray equipment? No, that's not in their skill set. And so there's a really interesting question as to what this means and whether anyone in fact meets it. But getting practical rather than esoteric, I think the test for general supervision is who would the tech go to if they had a question? If one group is providing all of the tests, I feel pretty good about it. Where this gets complicated are situations where more than one organization are sharing a piece of equipment or where techs are being leased. And when that's happening, you have to organize in such a way that your techs know who's supervising them. And you have to be prepared because if Medicare were to show up and ask your techs, I want to say, who's your daddy? Who's supervising this test? They have to be able to answer it.
And it's interesting, David, I've heard stories from actual clients who say that, and you're going to get to IDTFs, but the same idea applies, that one of the easy ways for a carrier to ding you is to call up a tech or an office and to ask the tech if he or she knows who they're supposed to be calling for supervision purposes. I think this is even more important in the IDTF setting because you have supervising physicians, but I think the bottom line is that the tech should have some idea of who's supposed to be in charge of these things.
So, all right. Now, let's talk on a big trap. So a big trap is that only doctors can supervise diagnostic tests. So if we go back to that law, which perhaps I should have stuck here, it talks about a service. Any service a doctor can do, an NP or PA can do. Well, for whatever reason, Medicare doesn't consider supervision to be a service. It's something else. And so in their mind, NPs, PAs, and that's supposed to be clinical nurse specialists, not Canadian National Railroad, I lost an S, sorry, can't supervise tests. So physician extenders can order them, they just can't supervise them.
And that's true in the hospital setting, too, for diagnostic tests. So that's one commonality between office and hospital for diagnostic.
And they also can perform the tests in certain situations. They just can't supervise them. Okay, IDTF supervision. I want to mention this just quickly because it's supervision related. In an independent diagnostic testing facility, an IDTF, tests require additional supervision. If you have the choice of being either a physician practice or being a hospital or being an IDTF, pick one of the first two. You don't want to be an IDTF. So an IDTF, a physician can only supervise 3 or fewer sites, and the supervisor has to, quote, evidence proficiency, unquote, in the performance and interpretation of tests. Now, what CMS says about that is basically that's left up to the discretion of the local carrier as to what it means. And only the supervisor of record can do the supervision. If you're looking to become nauseous, you can read U.S. XRL Hobbs versus MedQuest, which is a case that came out in 2011. It's not great facts for the organization, but an $11 million False Claims Act verdict was rendered, where the claim was that what had been a physician practice was now actually an independent diagnostic testing facility, but they have failed to update their enrollment forms, and they lacked sufficient physician supervision. Reading that case is chilling on a bunch of levels, but it highlights the need for supervision, and it even gets to something Katie's going to talk about in a little bit, which is how carefully do you record the level of supervision. One of the lessons for me on this, I think that the case was misnamed. I actually think it's XRL Hobbs versus Kelvin, based on the following. Oh no, I have to go to the bathroom. Monsters will get me as soon as I set foot on the floor. And if you're like I am, this was a real fear. My last step into bed was always a leap, because I was convinced an arm was going to emerge from under the bed and grab me and pull me underneath. Hobbs says, I know, put your pillow down as a decoy. While they're eating that, you can slip out. And Kelvin thinks this is a great idea. I'm coming out of bed now. Here I am, all fat and squishy. Well, it works. They took it. Man, look at the feathers fly. You'd better hurry. This causes Kelvin to reconsider. No, I've decided to stay here and wet the bed, but it's okay with me if you don't want to stay. This case is a chilling illustration that there really are monsters under the bed right now. I think there's going to be a lot of enforcement on the supervision front, and so we're going to have to pay attention to the stuff I'm talking about here and the stuff Katie is going to talk about now.
All right, so what I want to do now is take you back real quickly to the Medicare statute, because now we are switching benefit categories. We are going from diagnostic tests in the non-hospital setting, which David just talked about, to 2 new benefit categories. The first one being hospital services that are incident to physician services rendered to outpatients. That's the category we commonly know as hospital therapeutic outpatient services. Then the second one we're going to talk about is diagnostic services that are furnished to outpatients. So there's an entirely new benefit category for diagnostic services in the outpatient setting. So we're going to have different rules for that as well. Let me just briefly touch on what in the world therapeutic services are. Basically, if it's not a diagnostic test and it's not a physician service and it's not a PT, OT, or speech language service, then it's a therapeutic service. This is a catch-all category. And I think the best examples are things like infusion and chemo and observation services that are provided to outpatients. I will note here, just a reminder that Incident 2, the language that you see in the statute for Incident 2 in the outpatient services setting, it's not the same as the Incident 2 billing rules in the office. So try to ignore that. CMS has unfortunately used the same phrase to refer to two different things. Big picture, when you're talking about hospital outpatient services, you need to think about all of these supervision rules. And then Incident 2 services in the office, there are different billing rules. So if you've been even remotely in touch with CMS rulemaking over the past few years, you know that the evolution of this supervision of outpatient services has been quite tortured. But the good news is that I think CMS has finally settled on some concepts that we can wrap our head around. The only thing you need to know about the past is basically that at one time, for a long time, CMS used to assume that if you were on campus, you were meeting the supervision requirements for outpatient therapeutic services. And so people didn't really care about the rules because CMS wasn't enforcing them. Now we have to care about them because there are actual real standards we need to meet, and there's no more assumption. So if you have a therapeutic service, it needs to be supervised. Who can supervise? Differently than diagnostic tests, it can be a physician or a non-physician practitioner, and I've listed those here. So long as that supervising practitioner is acting within their state law scope of practice, can't be doing something that you're not licensed to do, and you're also consistent with the privileges that the hospital has given you.
I'm just going to chime in there because for a while we were hearing red herrings. People would get really torqued off about this privileges thing, and it turned into a whole bunch of questions about privilege. And I think that's something that's within the hospital's control. And the way it's worded, it really is you have to be outside the scope of your privileges.
Right.
And so, I think that that's a red herring. But you will sometimes hear lawyers who turn this into a concern, and I think it's a fake concern. As long as you're not doing something that the hospital forbids, you're okay.
Right. The one exception to this who can supervise rule, in it being a bunch of non-physician practitioners, is that for pulmonary and cardiac rehab, it must be a physician who's supervising. Now, I've already had a question about whether that physician has to be board certified, and I need to look at the rules, so I will answer that person's question, and if other people have it, they can email me. But it has to be a physician in those cases. Now, interestingly, just to confuse you, the statute for pulmonary and cardiac rehab has put back in the assumption that if you're on campus, you're meeting the supervision requirement. So it's sort of this weird, CMS doesn't assume anymore, but for pulmonary and cardiac rehab, they do assume you meet it so long as you have a physician doing it. The default rule for outpatient therapeutic services is that you have to have direct supervision. What CMS gives us for a definition of that is basically that the supervising practitioner has to be immediately available, we've seen that before, to furnish assistance and direction throughout the performance of the procedure. It doesn't mean you have to be present in the same room. So that's the rule definition. What in the world does immediately available mean? There have been various iterations of this by CMS. There's still no official definition, but we do know from their commentary that you have to be able to be interrupted if you're the supervising practitioner. So you can't be in the middle of open heart surgery with your patient on the operating table and then be called away, because I would hope that you wouldn't be able to be interrupted in that situation. You also have to be able to respond in time to change the course of treatment if that's necessary. What CMS has done in its final determination is that it said we are not going to impose a geographic boundary. So you don't necessarily have to be within the four walls of the hospital or on the hospital campus. Maybe you could be on the golf course that's next to the campus so long as you can go in and change the course of the treatment. I don't know if that's actually possible, but point is there's no geographic boundary. And this has been helpful, particularly for hospitals that have a medical office building next to the hospital. If the physician who's supervising is in his or her office doing charts and they can still get to the procedure to change it if they need to, then that's going to meet the standard here. These new standards caused a lot of angst for smaller hospitals because this is a real staffing burden to meet these requirements. And so what CMS has said is that they are going to delay the enforcement until January 1 of next year for any critical hospital, access hospital, and a small rural hospital, which they're defining as 100 or less or fewer beds. Now, there's, of course, as always with CMS, another exception to this direct supervision requirement. There's a new group of services called non-surgical extended duration therapeutic services. Fancy title, basically, for a list that CMS is going to publish each year with the outpatient prospective payment system rule, which I've linked at the bottom of this slide. And it's a list of procedures that basically CMS has said, okay, so these aren't such a big deal that we need to have direct supervision all the time. But we definitely want there to be direct supervision at the initiation of the procedure. And then once the initiation is over, then there can be general supervision. And that basically means that's the rule that David talked about earlier, where you're responsible for the equipment, and if I'm recalling it right, but you don't necessarily have to be immediately available. Now, I'm not totally certain how this works from a practical standpoint, because even if you are doing some of these non-extended duration services, I don't know how you could sync it so that all of them started at the right time and then moved to general supervision at the same time, such that that would somehow relieve the staffing level. But we'll take what we can get and pay attention to these rules, or to this list, because it could change. Right now, it's basically infusions and injections, but people are hoping that chemo will be put on there soon. And then the other change for this year is that there's now a panel that is going to be looking at various services to see if they either need to have a lower supervision requirement or go up to personal supervision. So be aware that there's a panel out there. It's not a rulemaking process, so they're basically going to post their recommendations, they'll take comments, and then they'll recommend to CMS what to do at these levels. Now, there's been a promising first meeting in that the panel didn't require more supervision for things, and instead they said, okay, for things like smoking cessation, we're only going to go for general there. So we'll see how that plays out.
Do you think that the hop is either an invitation for a Kermit the Frog thing, or is it really is it something to do with pancakes?
Hopefully it means that the supervising practitioner can hop between on-campus and off-campus and not have to meet certain immediately available requirements. Okay, so now we're switching benefit categories again, and we're talking about outpatient diagnostic services. So new set of rules. The same rule that only physicians can supervise diagnostic tests applies in the hospital. So this is a really big trap. You got to have a physician supervising. And it's sort of convenient in that you can look at the supervision level in the fee schedule to determine where you need to be. The one thing being different is that for the office setting, direct supervision means you have to be in the office suite. Whereas in the hospital setting, you could be, like I said, at the coffee shop next to the hospital campus if you can interrupt, or if you can be interrupted and respond. Now, then, of course, we have another little carve-out exception, where if you are a provider-based department and you're off campus, and the services are being provided under arrangements, in that case, if the test requires direct supervision, then that physician has to be immediately available and present in the office suite. So I'm going to call on David to sort of give me an example of when we might be in this carve out to the exception.
For in the office suite?
Right. For the off-campus under arrangements.
And David's going to blank right now and not come up with a very good one.
Perhaps a PT.
PT would be a good. Okay, so I think a good example of that would be a clinic having a PT. Imaging would be the other one. Yeah. Diagnostic tests. So maybe the hospital is contracting with the local clinic to get a CT scan done. And physical, I think I'd see it most with physical therapy and scanning.
Yeah. Yeah.
And so you're using an off-site physical therapy location,
Right.
off-site scanning, something like that.
And you're provider based. In that case, if you need direct supervision, you have to be present in the office suite. You can't be at the building next door.
Yeah, and what's I mean, I think this is really confusing for us, and so but it's important to say therapeutic and diagnostic are different, and both in kind of all settings. It's always good to think about when you're asking yourself what level of supervision is required. Ask, is this a therapeutic service or is it a diagnostic service? That's sort of step one. And I guess step 1A is it in the hospital or is it in the clinic?
Right.
And if you're actually the hospital and clinic are sort of similar for diagnostic tests in that only physicians can do them. And then, in therapeutic, you only have to worry about stuff in the hospital. Therapeutic in the clinic, actually, we're going to talk about in just a moment. That's really the incident 2 stuff.
Right. And one other point to think about with all of this is how do you document it? How do you establish a record that you're meeting these supervision requirements? Because I think enforcement on this is going to be big. We've seen key TAM lawsuits with whistleblowers bringing this up. So you don't want to have a documentation system that is confusing for people, because I think you should also use your documentation system for people who are performing the service to be able to know who to call if there's something that goes on. And there's a question of whether if you document it for one day and then you forget the next day, well, does the government auditor that's coming in, do they have proof that the supervision wasn't actually done? Well, David and I in a defense setting, we would say we have a number of other things to prove their supervision. We have physician schedules, we have testimony, affidavits, and those sorts of things. But I guess the bottom line is you want to record this, but you want to do it in a way that's going to be helpful to your organization.
Yeah, and we had a situation, we had an appeal in the desert Southwest for an oncology group where Medicare wanted $3 million from a doctor because they questioned whether he was present to supervise chemo, and we were able to prove that up, as Katie just talked about, with physician schedules. I think what I struggle with, a lot of places have a doc of the day, which is great, as long as it's real and the person's there. If you have a doc of the day, does that mean the doc of the day can't go out to lunch? And do you have a mechanism to trace it? And I think one of the biggest challenges is if you start having documentation and it's inconsistent, is that worse than not having it at all? And we can't answer that one. I don't know the answer. I know I struggle with this. Okay, incident 2. As we've talked about, that's confusing for incident to a physician's professional service. So this is something that's designed to cover work that's normally initiated by the physician and included as part of their bill. So the requirements to bill incident 2 are both, it's always good to think of the hierarchy. There are actually regulatory requirements, and then they're explained further in the Medicare manuals. So the first thing is that the clinic has to be paying the expense of the ancillary person. They don't have to be an employee. It's interesting because the manuals even use the word employee, but least employee is okay. So it really is the clinic has to be on the hook economically for it. The clinic has to be providing the medical direction, and then that's not usually a big deal. Here's the one that I think is often the biggest trip up, or maybe the second biggest trip up. The first visit for a particular illness or injury has to be with a physician. Later visits can be with the non-physician practitioner. And actually, this is poorly worded by me in a way, because you can be incident to an NP or PA. You would just be getting paid 85% of the fee schedule. So you could substitute physician there for NP or PA in some circumstances. It dawns on me right now, actually, as a question is coming in. I don't know that we've said, you can always type in questions in the lower right part of the screen. We'll probably do most of them at the end, but we might pause it some way along the line. So if we're confusing the socks off of you, or if there's just something we haven't covered, type it in the lower right. All right, let's look at how CMS describes course of treatment. And this is worth just reading out of the Benefit Policy Manual. So it doesn't mean that each occasion of service by the auxiliary personnel needs to be the occasion of an actual rendition of a personal professional service by the physician. It can be considered to be incident to when furnished during the course of treatment when the physician performs an initial service and subsequent services of a frequency which reflect his or her active participation in and management of the course of treatment. So what's interesting is, what is a course of treatment? Generally, people think if you have a new thing. So well, let's operationalize it in the office setting. Ear infections. Your kid, shockingly, has multiple ear infections. You have an ear infection, and 6 months later you come in for a new ear infection. Is that one course of treatment because it's all ear infections, or is each of those two independent? There's no answer to that that's clear. I'd feel comfortable trying to defend it's part of a course of treatment. I'd feel pretty darn comfortable saying that's part of a course of treatment because it doesn't really say each new illness. That's often how things once again get shorthanded. It's how I shorthanded it in the slide, but it's not what the course of treatment says in the manuals. So there isn't an operational definition of course of treatment. I do feel like, so I feel less good about broken arm and then, if you're in an orthopedic practice, come in for a broken arm and then they come in for a broken leg or the other broken arm. That doesn't feel as course of treatment-y to me as the ear infections do.
David, what about if you haven't one illness and you believe that was sort of the reason for the next illness?
Yeah, to me, that feels like a course of treatment. And frankly, all of our collective judgment here is, I don't have any authority I can point to. So it's use your judgment as to what you feel like course of treatment feels like. Okay. Incident 2 billing has to be something typically done in an office. You can't do it with brain surgery. Here's the other really big trap. The service can't be in a hospital or in a skilled nursing facility. Places that have facility fee payment. Well, actually, that's even too. So it really is hospital or SNF because there are other. In fact, Katie just taught me this recently. I think in ICFs, there is a facility fee payment, but you can be incident 2. Katie is perpetually teaching me new stuff. Okay, you have to have a clinic physician who's in the office suite, as we've discussed. The service has to be billed under the name of the supervising physician. So this is, let's say Katie ordered physical therapy for a patient, and I'm the one who's around when the physical therapy is done.
Lord help that patient.
Yeah. In that situation, it has to be billed under my name, okay? It can't be, even though Katie ordered it, I'm present. Now, you may be familiar with shared visits. That can happen in the hospital context. This is worth noting because you can do a shared visit in the hospital. You can't do incident 2. So a shared visit is both the extender and the physician seeing the patient on the same day, and you're combining their work into one big visit. That's still okay. That isn't incident 2. It's a shared visit. That's a different animal. What you can't have is the physician extender conduct the visit without the physician being there, or even being there but not being in the room. And then finally, it can't be used for a service that's an independent benefit under the program. And so a classic example of that, and this is a change, it's a change from 10 years ago. In 2002, when this change happened.
Change is a change.
Yes. We used to think you could do diagnostic tests, incident 2. Diagnostic tests are a separate benefit, so you can't do it. Now, this raises an interesting question for Katie, who's looked at this more recently than I. Can I bill one physician incident to another physician?
It's an interesting question. The short answer is that there's not really a good answer to this. Now, if you look at what is an independent benefit under the Medicare program, physician services are an independent benefit. So that's an argument against using the physician billed incident to another physician. However, CMS has said that the definition of auxiliary personnel, which is, remember, those people who can do these incident 2 services, that definition, they've said they are specifically not going to define in terms of practitioners because they want it to be flexible for people to use the incident 2 benefit. So I would look at that language in the commentary and say, well, that's kind of support for the idea of doing physician incident to another physician. I would actually probably only use this argument because it's a little bit precarious in the situation where you have a physician who needs to be doing maybe who isn't credentialed yet, and you can't meet the locum tenens billing rules, and you can't meet the reciprocal billing rules. And so in those cases, I would maybe use this strategy, but I wouldn't recommend it for a long period.
And I'd put it even a slight. I would say this is the classic example of where I might use it to defend something that's happened, but I don't think I would try to get there on purpose. I don't know that I would set it up to be relying on this one, but I would gladly use this if it had happened, in those when you get the call, oh, by the way, we've had this person providing services for a while. And just because I want to make sure I was really clear about this because it's come up so many times, if you've got an NP or PA who's going to the hospital or who's going to a nursing home, they've got to be billing independently. You can't do that incident too. We've had that come up a boatload. Okay, so what are the pros and cons of Incident 2? For most services, you get better reimbursement if you bill Incident 2, meaning you're billing under the physician. PT's paid the same way, so there's no real pro there. Another pro, and this is not so much a pro, but it's a difference, I guess. For those of you who are into giving production credit under Stark, you can give production credit for stuff that's done Incident 2. So if you want to pay an oncologist for supervising chemotherapy, that has to be done Incident 2. That's the only way you can get the production credit into the formula and still be Stark compliant, at least if you're a for-profit type clinic. If you're a nonprofit, many of you guys think you can blow off Stark, and you often can, but if you're giving production credit, just this is an aside, it isn't really exactly on our topic, note that if you're giving production credit, you are now relying on the in-office ancillary exception, which, by the way, would mean you'd have to give notice to people for advanced imaging. Different topic, I just mentioned it here. So what are the cons of Incident 2? Well, perhaps the biggest is you can't take a patient who's coming in from the outside without initiating the course of treatment. So, for example, physical therapy. You have to see the patient to initiate the course of therapy. And so that's a fairly significant negative. If the person comes in with a new problem that's not part of the course of treatment, they've got to see a doctor. You got to bill under the doctor who's there, and you can't do it in the hospital. So I think we've covered this real estate fairly well. Am I missing anything? All right. So we're going to talk for a couple minutes about signature requirements. Now, there are many signature requirement type entities. We're focused, remember, on Medicare. There's also Medicaid and private insurers. There are the conditions of participations. There are the accrediting bodies. There's licensure. I think we may have considered going into all of those here, but we have an hour, so we ran out of the ability to do it. And I just don't know if we're smart enough. I will note that when you're reading things, it's easy to get trapped on the difference between written and signed, or heck, written and not written. So let's say a physician order is necessary. A physician order is necessary does not mean a written order is necessary. A written order is necessary does not mean a signed order is necessary.
And I think the manuals even use the term authenticated, which is not really a signature requirement.
Yeah.
It's sort of identifying that you did something.
I think
so maybe it could be initials.
Like a little or a thumbprint.
Or a thumbprint,
I don't
yes.
know. But this is important, and it comes up a lot. So do you need to sign all of your office notes? Here's one of those places where your defense position, the short answer, practically, sign them. Legally, do I think you have to? No. I base this on a few things, but this is a place where there's internally inconsistent guidance. If you go back to my young pup days as a lawyer, what was then HICFA put out a joint question and answer sheet, and you've heard me allude to this in the "if it isn't written, it wasn't done" world. So that the 11th question on there was, is the physician's signature required on each page of the documentation? And the answer was no. The guidelines only state the identity of the observer must be legibly recorded. Here's what the program integrity manuals say. They say if the signature is missing from an order, MACs and certs are supposed to disregard the order in the review process. Now, I don't know exactly what their authority for that is. Katie's going to talk about that a little bit, but I don't think there is authority for that. But let's just put that one aside for the moment. If the signature is missing from any other medical documentation other than an order, then you can accept a signature attestation from the author of the medical record entry. Now, remember, manuals aren't the law. I just love to say this because it's so offensive to me. A person relies on the manuals at his peril.
Which I think would be a great quote if somebody comes back and says, you said on your 855A that you were certifying everything was in compliance with the program instructions, and that includes manuals.
Yeah.
So just keep this in your back pocket.
Yeah, so the government is willing to say that we shouldn't listen to their stuff. They've said it in courts of appeals, but okay. If you get a cert request, the cert request will say things like, you can sign these things when if they're not signed, you can sign them now. So I don't want to go into that in gory detail, but it all highlights the principle that you don't have to sign charts.
And it's important. I interrupted you,
Yeah,
David.
no,
I'm sorry.
that's okay.
But I do know that a RAC near you is looking at this, and they're probably wrong. They're probably saying you have to sign the charts, and there's a good legal argument that you don't have to. And I've heard just today that Iraq is denying claims on this basis. So
And
it's out there.
Just to be clear, that's recovery audit contractors
yes.
and not the country in the Middle East.
Yes.
All right. I learned something actually preparing for this about diagnostic tests. There are actually in the regulations specific requirements about diagnostic test record keeping. And this is just interesting to note. I won't read it aloud because I put the text in here so you could kind of peruse it at your leisure. But basically note that it says that if whoever orders the service has to maintain documentation that it was medically necessary. It doesn't say what it is. The person submitting the claim has to document that it got information from the ordering physician. So I didn't know this was in here, but I think it bolsters the idea that you can supplement information later on, because it talks about in the event of a claims review, they'll go in and ask for the information, and if they don't have it, they're supposed to kind of go check on it. So this just bolsters that if you don't have documentation, you can back things up. Okay, and so I just left that material in here for you to read. It's an interesting to note. Now, what's really weird when you get into IDTFs, whole nother ball game. Okay, and this highlights the differences between things. And CMS is increasingly saying you have to have written orders in all kinds of situations. Well, here's one of the reasons we think that's not true. So IDTFs have to specifically have orders in writing. That's in the regulation. The number you see in the bottom right is the regulation. When this came out in Halloween 1997, here's what CMS said. They said, why are you putting higher rules on IDTFs? Well, we'll tell you why. What used to be IDTFs, which were then IPLs, which is, I think, independent physiologic laboratories, have offered free screening, and we think they're really skanky, basically. So we believe that our experience with waste and abuse in IPLs justify these additional requirements for IDTFs. And so they were explicitly setting a higher bar for IDTFs than everyone else. So IDTFs have to have a written order, and this text is recognizing that at least in 1997, CMS thought you didn't need written orders in a wide variety of other settings. I'm now going to turn this over to Katie, who's going to talk about some other sets of orders.
Okay, so the DMEPOS world and orders for DMEPOS are, this is a perfect example of where we have a hierarchy of rules, guidance, manuals, and they're all different. So this is where we're going to employ the strategy of what's the advice going forward and what do we need to do to defend something. So basically for DMEPOS, there are two separate regulations, and the rule for DME items, durable medical equipment items, and the rule for prosthetics and orthotics, which are separate, say that CMS may require a written physician order before delivery of these items. Okay, so that's all the rule says. That's all the law says. Then the program integrity manual, so now we're at the guidance level, says there must be a detailed written order that is signed by the treating physician for DMEPOS. So three differences from the rule. The first, detailed, that's totally new. That's not in the rule. So CMS is basically now requiring a detailed written order. Second, it has to be signed. The signature requirement was not present in the rule. So this is an additional requirement imposed by the manual. And then they're also putting together DME items and prosthetics and orthotics. So saying you have to treat these all the same, which is again different than the rules, which potentially treats them differently. And then it also says, the program integrity manual, that you have to have the signed order prior to billing, or the contractor will deny the service. Now that's different than having it prior to delivery. And all of you on the ground can, I think, attest to the fact that delivery and billing are going to be different times, and delivery might occur before or after billing. So now we have a new kind of basic set of rules from the manual. So then, if that's not bad enough, there's more manual guidance. For example, the first bullet has the rule, or the guidance in the manual, that says, for leg, arm, back, neck braces, trusses, and other artificial items, Those things are covered under Part B when they're furnished incident to a physician's services or on a physician's order. So this implies that you don't have to have an order at all if they're incident to. That's totally different than a detailed written order signed by the treating physician before the billing.
So remember when we talked about how sometimes the manual guidance is internally inconsistent? This would be Exhibit A.
Yes. And then the next bullet is basically showing you that there's this weird language about how the physician doesn't have to necessarily complete the detailed description, but they definitely have to review it and sign it and date it in order to indicate their agreement. So there's this interesting language about who can do it, which is just another added layer of confusion. So point being, for risk management purposes, I would say write it down, make it detailed, sign it, and have it before you bill going forward. Then I think you're in the safest position under the manuals and guidance. But if I'm looking at an audit and I'm defending somebody, I'm going to say, well, actually, the only thing that the rule said that CMS can require is a written order. And so if we have that, then we're okay. I also want to mention this fairly new rule, like in the past, I think 2 years or so, that I don't think people are really very aware of. And it echoes the rule about documentation for diagnostic tests that David just mentioned. Basically, this is sort of, I want to call it a hybrid rule because it's under the section that lists the reasons why CMS can revoke your billing privileges. So it's not exactly a condition of participation, but it's not necessarily a condition of payment. It's just sort of a rule that can get you kicked out. So it's important, and it sort of relates to payment, obviously. So looking at the rule, basically it says that a provider or supplier who furnishes these buckets of services basically has to maintain the documentation about who ordered it and how they were billed. And look at the last 3 sentences. It says, relating to written orders and requests for payments of these certain services. This implies that you have to have written orders for all of these things, which would include imaging, specialist services. I don't even know what that means, and I don't think that's defined anywhere in the rules. So be aware that there's this sort of funky regulation out there that could be used as a basis to argue you have to have written orders for everything. I think, my defense is that you have to have documentation of requests for payments for everything, which you have in claims, and written orders when the rules otherwise require it, but it's not entirely clear.
And one important point, an order does not have to be a separate freestanding piece of paper. I mean, a dictation in the doctor's note that says, give this person a piece, give them a crutch, that's an order. So, I mean, I don't think there's any dispute about that part of things. Okay, we have a lot of questions, so I'm going to do standing orders in about 30 seconds. They're okay. Medicare doesn't really focus on them, and in their mind, an order is an order, and I'm not going to read to you, but I included in here the backup, which is some language from the OIG lab compliance guidance, where they basically talk about standing orders and say, they can be sketchy at times, but Bob, basically goes on to recognize they should at least have a fixed term of validity and must be renewed at their expiration, which is pretty conclusive proof that a standing order is still an order. And I mean, that's what I'd say. The standing part, it's an order. And so if a physician has ordered it, you're okay.
All right. Lab services. Unfortunately, another area of confusion. I want to tell you what's out there and then talk about what's good going forward and what's good going back. So, the last rule we heard about retaining documentation implied you had to have a written order for lab services. We don't exactly know if that's really a rule. The Halloween 1997 rule that David talked about said that basically it implied that don't have to be written orders for anything besides an IDTF. So that's good for lab services. We don't have to have a written order. Recently, CMS proposed a policy, and interestingly, not in a manual or a rule, just in the preamble, that the ordering physician or non-physician practitioner has to sign lab requisitions. So lab requisitions, I learned, are basically the form that you complete and check the box for the lab test that you want, and then the ordering person has to sign it. Well, people were up in arms because this is sort of ridiculous and not the precedent. So CMS actually retracted that and said, no, fine, we don't have to sign the lab requisitions. You do have to document that the order of the test is there. And then it referenced this long-standing policy that requires orders, clinical lab tests, and other things to be signed by the ordering physician or non-physician practitioner. Now, I don't think, and I'm pretty sure David hasn't seen any sort of long-standing policy that requires all orders to be signed and written, as we've just demonstrated. But know that CMS is confused about this, and going forward, it's good to just dot all your I's and cross all your T's, get things signed, but don't be in despair if you haven't done that going backward. Okay, I want to get to questions, so I'm going to try to breeze through certifications pretty quickly, which is hard because certifications are important. But I'm going to make the basic point at the beginning that's the most important point here to take away. Certifications for home health and for hospice are extremely counterintuitive in how they're supposed to be done. So every time I give advice on this, I have to look at the rule like 5 times and then look at it again the next day. So I put the rules in here and make sure especially before you create a form that people are going to be using for these things, make sure that you read the rule over a few times so that you know exactly what the form is supposed to say and what the physician has to do and then how you're supposed to sign it. So for home health, the physician is certifying, and it has to be a physician, to a number of different things, which I've listed here. The biggest new thing is that the physician has to perform a face-to-face encounter with the patient, interestingly, to certify that they're homebound. So David's pointed this out, and it is crazy. You have to get the patient out of their home to the physician to certify that they're homebound. It's not exactly helpful, but that's the rule. And there's a certain time frame for when this has to happen, so make sure you pay attention to that. The face-to-face encounter certification isn't just dating, I saw the person and here's the date and here's my signature. It requires a few different things. You can have a physician, non-physician practitioner do them, but then they have to communicate all the findings to the physician. You have to have the face-to-face encounter has to be related to the reason for home health. So if you saw the patient last month, but it didn't relate to anything that had to do with them being homebound and needing services in their home, then you have to basically see them again to do another face-to-face to get the certification. And then you also have to say why the clinical findings support the fact that the patient is homebound. So it's not just, a sign and date type of thing. Now, in some cases, which I'm not going to go into the specifics, but in some cases, the rule requires you to write a narrative. And if you have to write a narrative, make sure that the physician is signing both the narrative, if it's an addendum, and the certification itself. If you don't sign the thing that you attach to the certification, then arguably you don't have a valid certification.
You gotta love government.
And then if your head isn't spinning enough, you have to make sure you recertify every 60 days. All right, so we're moving to hospice. New benefit category.
We'll run over by a couple of minutes, but we will answer the questions.
Yes.
There are a bunch of good questions,
Yep.
So we'll cover them.
All right, so same ideas here. The regulation is key. Read it 5 times and then read it the next day. You have to have a face-to-face encounter, but only if the patient is anticipated to reach their 3rd benefit period. And I think the benefit periods are 90 days. So if they're going to get to the 3rd one of those, then you have to have the face-to-face encounter. And that has to occur 30 days, at least somewhere within the 30 days prior to that 3rd benefit period. So there's a face-to-face encounter here, but it's not automatic. Again, with the narrative thing, if you have a narrative, make sure that the signature is immediately following the narrative, whether it's on the certification form or it's on the addenda. I sometimes think it's just a good idea to have the physician sign and date every part of the certification if you want to be super careful. But definitely make sure, if you have addenda, that they sign those too. And then you have to include the benefit period dates. There are funky timelines for hospice too. The general rule is you have to have the certification prior to billing, but you have some flexibility there in that you can get a verbal certification and then that followed up by a written certification, so long as it's not later than 15 days after the start of the hospice. And then you do need a recertification for each 90-day benefit period. And it has to be 15 days prior to the benefit start date. So take away from here, read the rule, run it by somebody, and make sure your physicians know how important it is to get this certification right. All right.
All right.
Questions?
We've got a ton of questions. I'll do the first couple here, and then I think we're going to probably split a bunch of these. So the first one, you've said two different things about the presence of a physician when billing incident 2. In one slide, you said a clinic physician had to be present, and in the other, you said the billing physician had to be present. The question is whether we can bill incident 2 one physician if another physician is present, but the incident 2 one is not. And so, in my mind at least, that was not two different things, which is you do need to have a clinic physician present, and then whichever clinic physician is present is by definition the billing physician, because you've got to bill under the person who's providing the supervision. It's I guess this is almost good to think of the ordering physician here. I mean, order is the wrong word, but the physician who established the plan of care is not the billing physician. The billing physician is the supervising physician.
Yeah, and the reason is that is because you're billing for the supervision that's provided by that person who's present.
Yeah, so the name that goes on the claim of an Incident 2 service is a doctor who is present in the suite at the time. So hopefully that made sense. Okay, kind of a related question. I would like to know if a physician assistant can see a new patient for consultation, and I'm going to use the word consultation even though Medicare got rid of their consultations, of lower extremity pain in an office setting and bill under their own number. Can you bill Incident 2 using the supervising physician's NPI, or are you saying a PA cannot see a new patient for the first evaluation? And I'm getting a little confused by this one, but if it's a new, if you're billing under the PA's number, that's not Incident 2, and yes, they can see a new patient. If you're billing under the physician's NPI, now you are billing Incident 2. And if it's a new problem that's come up, I would say no. Otherwise, we're back to whether it's the course of treatment. Now, here's just kind of a fun one. So, Katie, do you think pregnancy is considered an illness?
I think I would make the argument that it's one course of treatment.
Yeah, I think it depends. I think it depends on your perspective.
Some days you might think that it's an illness. Other days it might be the best thing ever.
But I would say that there is a course of treatment. And I think that the point of the question was, now the good news is, and this is another thing to keep in mind, pregnancy is rarely going to fall under Medicare coverage. Yeah. It's more likely to be Medicaid, and we didn't really get into the Medicaid Incident 2 requirements, and there's a reason for that. We've got people on here from probably 25 different states, and each state has its own Medicaid requirements.
Just another thing to think about.
Do you have one you want to do?
I do, and I think you might have to weigh in here too. So this is an interesting question that involves EMR, which always puts a nice spin on things. So our physicians currently order imaging on paper. We then have a medical records staff member put that order into our EMR. The records person signs the order note, and the paper sheet goes back to our imaging vendor, so it never comes back to us to scan into our record. Is this okay? This is like a law school exam question. So the first question to ask is, do you have to have an order documented?
Well, and it's interesting because it sounds like this is going to an off-site imaging facility, in which case, really, the burden's probably on that off-site imaging facility, and that's who you're sending it to.
Right.
Now, except we're back to the cause to be presented. Now, this is back to the difference between written and signed. I think you have written.
Yep.
I mean, a really interesting question. To me, if you dictate something and it is written up, that's written. You know, I don't know what else written means. So this sounds really okay to me. I'm okay.
It does. I'm not crazy about the fact that you never get the thing back, so you can say that you had it written. But
I feel pretty zen-y
But
about
it's
it.
okay.
If you're imaging things, it wouldn't hurt to image it. But I feel pretty good about this one. All right, please define the physician must see all new problems like minor one. Well, this is kind of the same thing. Okay, I'm going to skip that one for the moment because I think we've kind of covered that one. Here's another EMR question. We recently began using an EMR to generate orders. When an order is generated, the order states authorized by and signed by. If the order is authorized by a physician, can someone else sign the order, like an MA or an X-ray tech? Well, most of these don't. if you think a signature is required, I think it's got to be the doctor.
Yes.
Now, I would argue that for most of these, a signature isn't required.
Right. But you don't want somebody to be ever signing something that they didn't do, and that in a way that represents that they actually did it.
Which highlights, I mean, in the EMR, the shared password problem, which is endemic, is a huge problem. If an MA or an X-ray tech has the doctor's password and can sign stuff, all I can say is yikes. And I think,
Right.
I mean, I know this happens a lot. I was working on a thing recently where we found a Google document that had everyone's in the department's passwords on it, and that's sub-ideal.
Okay, now we have an office visit one. If the office visit note is unsigned and the office visit note documents the physician's intent to order the test and there is no separate order, does the office visit note need to be signed? Okay, a couple different things going on here. You heard David's spiel on whether an office visit note has to be signed, and there's a good legal argument that it doesn't. If there's an order, you have to ask whether it has to be written and signed. And like David said, and we talked about, there's an argument that many of these tests don't have to have written and signed orders.
And I'm just going to interject one thing just to say, I do think you should sign. I mean,
Right.
I would recommend signing them.
Right.
But what Katie said is spot on accurate.
Right. And again, I think this highlights that you don't have to have a separate sheet of paper that has the order. It can be in another sheet of paper that you then sign. So,
can a nurse practitioner bill incident 2 if seeing a pregnant patient for their first visit? Well, I'm going to focus on the pregnant for a moment to highlight this gets to our Medicare question versus. It's very important to remember different payers can treat things differently. You know, people think you can't discriminate, and so we have to treat all patients the same. Payers can discriminate, and they can have different things. And so you could even have technically an insurer who requires you to bill incident 2. It's possible. I don't know that many do, but you could. Medicare, the answer would be no. Now, the odds are this person isn't Medicare. The odds are that they're either Medicaid or some other private insurance. They could be disabled, so it's possible they're Medicare, just unlikely. Other insurance, you have to know what their local policy says. You know, Blue Cross can have a different policy from Humana, which can have a different policy from United Healthcare. And so all the advice we're giving is Medicare specific. You have another one, Katie? Or?
sure. This one asks, does the documentation need both a signature and attestation? So we've done our whole spiel about whether you have to sign documentation. I would say, though, that if you have a signature, that's an attestation.
Yeah.
That's the same thing.
The attestation language is coming from cert requests when you don't have a signature, which actually, by the way, I think really bolsters this notion of you aren't required to have an office note signed.
If you can submit an attestation later.
Okay, I think we've burned through most
Yep.
of the questions. You know, you can always get a hold of either Katie or me or any one of our colleagues. We're always happy to help on this stuff, anyone in the department. The next topic, the physicians, I think you'll be a little less interested in the next one. We'll come back in June with something good for you. But hospitals, you're going to care about the short stay one. And we'll talk about how you can challenge short stay things. Our last point, Katie, you wanted to make a point about topics, I think.
Oh, if we had known that this would be such a popular topic, we would have done it a year ago. So if you are hearing things you like or you have other ideas, please send us the ideas because we use them.
Yeah. So we'd love to know what you fill out the evaluation. We'd love to know more about webinars that would appeal to you. Well, thank you so much for putting up with a confusing topic. And I hope your Friday the 13th is kind to you.